YouTube, that is. It says preparing to go live stream. We have 2 attendees already. Hello,
Yes. Hi,
everyone.
Yinka, Malika.
Oh, you see them. Good.
Yes.
We're waiting a few. Oh, hi, Inka. How are you? Okay, we're live streaming to YouTube as well. So, and we got our own people joining us. Yay, woohoo! All
Yes,
right.
thank you for
Okay.
And then I'm not sure if you want to hit the record button, or maybe you want to wait until we start the conversation.
No,
It's up
I
to you.
have to hit the record button if I can find it. Now, record. Okay. All right, we're good. All right. So good evening, everyone, and welcome to a wonderful evening. This is Dr. Famuyiwa. I'm the host of Fertile Talks and the medical director from Montgomery Fertility Center. And tonight we have a wonderful lady to come share some knowledge with us. We have several questions that patients have always asked us about genetics and everything. So I thought, why don't I bring an expert to talk to us, to shed some light? So tonight we have Ms. Rawan Awwad. She is the Director of Genetic Counseling at Fairfax Egg Bank and Fairfax Diagnostic. And she's been there for several years and has great experience. And I would like her, Ms. Rawan Awwad, please tell the audience about you. They can't wait to hear about you.
Well, first of all, thank you so much for having me on this podcast. I'm very excited for our conversation today. And yes, I'm currently at Fairfax Egg Bank and Fairfax Diagnostics. I'm a genetic counselor by training, and I'm mostly focused on reproductive genetics. So a little bit about my background is I actually was born in Jerusalem and grew up in the Middle East. I'm Palestinian by ethnicity, and I came here when I was 18, thinking I would get my education and then go back. I fell in love with this country and everything it has to offer. I did actually practice a little bit in the Middle East. So one thing that is helpful for me now is that I get to understand a little bit more about different cultures and different languages and different backgrounds.
Awesome.
And I use that in my practice daily. But then, in addition to that, I started out my career with, in-person counseling at pediatric clinics, reproductive clinics. And then slowly, I really was drawn to the fertility field. So I worked in laboratories and counseling companies until I found Fairfax. And it's been really interesting along the way to learn more about the fertility field.
Excellent, Ron. That's so great. I'm excited that you're from the Palestinian, right?
Yes,
So,
yes.
and I'm from Nigeria. It's in West Africa, and I came to this country, I think it was 20 years ago. I was like 16 or 17 when I came as well. So right around that time, and when we come from Nigeria, they always say that you're going in search of the golden fleece.
Exactly.
So excellent. So I'm so excited to have you. Really pleasure to meet you. So
Thank
what
you for
I
having
want
me.
to, yes, what I want to ask you is, let's talk about genetic testing. And if somebody says, what is genetic testing? Why should I do it? What's it all about? And why should I care? Right? Especially
Yes.
someone from the Middle East or someone from where I come from in Nigeria. Why should they care?
That's a really good question. So when I think about genetic testing, I'm going to focus my discussion on the fertility field just because that's what we're specializing in, right? So there is genetic testing that can be administered to individuals seeking care, and then there's testing that can be administered to embryos. And in both departments, things have evolved a lot over time.
Yes.
When we think about testing for individuals, the number one and most common test that we administer and think about and discuss is carrier screening. And this testing has evolved, but the idea of it is that it's supposed to identify individuals who are at increased risk for having children with certain genetic conditions. Right. And a lot of the time when I have discussions with patients, the first thing I hear is what you're saying is, why should I get this test? I don't have a family history of any of these conditions that you're talking about. And that's a really good point because these conditions are mostly recessive, meaning that both reproductive partners must be carriers of the same condition for there to be an increased risk, or X-linked. And the vast majority of time, these conditions are not going to show up in a family history.
Right.
But because there's a common carrier status for a lot of them, then offering these tests on a population level is really important for assessment of risk. And so that's what I always discuss with patients is, although there's no family history, it's always helpful to look at your genetic blueprint and see if there's anything else that you need to pay attention to other than, clinical presentation of features.
Excellent. So you know what? I'm going to talk about, like, for my patients, it's very common, all right? Especially, like, we know that there's a high incidence of sickle cell in Nigeria, where I come from. People suffer from it. It's very debilitating. So in some areas, even, you can't get a marriage license unless you get a hemoglobin screen. And they'll say you're AA, AS, or SS, or whatever. And I know what that is, but can you tell our audience, especially someone who's coming from Nigeria, and they're saying, well, I had this thing done, so I don't need carrier screening. What is AASSS when they talk about that, right?
Yes, very good question. And I have to say that one thing I share with Dr. Famuyiwa is that in the Middle East, this type of testing is also offered and to get a marriage license.
Yes.
And so what you've probably gotten in your home country is something called a CBC, or complete blood count. That's also, in addition to that, is something called hemoglobin electrophoresis. They check for hemoglobin levels. We have different types of them.
Yes.
And from that test, they can predict if the person is a carrier for conditions like sickle cell. Now, sickle cell is what's called a recessive condition.
Right.
This means that typically a person who's a carrier of it is not going to express the condition itself. But again, when a partner is also a carrier, it increases the risk for disease for the offspring. And so it is very prevalent in individuals who are African American descent, as well as Middle Eastern, South Asians. And so offering that type of testing is routine, and it's by the guidelines. But what we're learning is that oftentimes when we're focusing on something called ethnicity-based testing, we are kind of ignoring risks for other conditions that can pop up if we are looking at more expanded panels. So what I mean by that is the carrier screening that's now offered is not just looking for risks of hemoglobinopathies like beta thal, alpha thalassemia, but there are other conditions that may be a little bit more rare, but could still be a risk for the couple. And so looking at those can really be helpful.
So in other words, the test that they're talking about is looking at the protein, the hemoglobin, right? It's not testing for the genes, people. That's not the genes. The protein is the output of the gene, of the DNA. So they're looking for the end product to try to go backwards to figure out, right? So that's not quite accurate. So if I were to call someone like you, Rawan, and say, okay, this person thinks that they were AS or AA, and why would I want to do a more in-depth DNA analysis to find the mutation, not the end product?
Yes, that's actually, you did ask me to explain the AA and AS, and I did not. So let me explain that more. Yes, you are correct. This type of testing that's administered is looking at hematologic values that indicate an increased risk to be a carrier for the S factor. So hemoglobin is actually a protein in our blood. It's carried by our red blood cells, and a very specific genetic variant in the HBB gene can cause the red blood cells to become a little bit more sickled. Now, by just administering a CBC, a complete blood count, and an electrophoresis, you are getting an assessment that would say that you have an increased risk to be a carrier for sickle cell, but only when we administer DNA analysis are we then confirming that carrier status. And if you are using that information to consider additional testing, such as testing on embryos or testing during the pregnancy, having just a hemoglobin electrophoresis and CBC is not going to be enough. The scientists in those labs would need a confirmation of the carrier status to then administer additional testing.
In other words, they need to find the exact mutation that's causing the problem. Now, Rawan, I know nowadays we use, in the past we used to test like 20 something genes, right? And you'd
Mhm.
find something. And then it went to about 200 genes. Then it went to about 400 genes. Now we're testing over 700 genes, right?
Right.
So can you comment on the fact that we're having so many genes that we're looking at, and what percentage of people would be positive using the more extended panel versus say if I just look for 20 things?
Right. So by nature, the more conditions we're adding to these panels, the higher the chance that somebody's going to come back positive. So I remember we used to quote something like there's a 40 to 50% chance you're going to come back positive on a
Yes.
100 gene panel, and now it's up to 80% chance. And
Yes.
so it's true that we are, we're able to identify more carriers, but I do have to say that larger doesn't necessarily always mean better.
Better.
And the reason being is that the idea is that adding more and more genes, you're now getting into a territory where you're adding more and more rare conditions. And the clinical utility of these tests, which are meant to identify carrier-carrier couples for recessive conditions, it becomes less of a possibility to identify that carrier-carrier situation if you're adding more and more rare conditions. Now, that said, I feel like there's a general preference in the field towards learning more.
Yeah,
If you can pay the
exactly.
same, if you're paying the same cost for a test that's looking at 100 genes versus 700, then a lot of people would want to know more. They can learn more about themselves, their gamete donor, if you're using gamete donors, etc. So I'm not saying that we necessarily should shy away from using larger panels as long as we get enough pre-test counseling to know what
Yes,
information we could be getting back.
exactly. So, and that's what we're finding out. So most people will have 3 or 4 mutations that you can find out. And that's why, getting those answers, we need to be able to talk to someone like Miss Awwad to, give it to me in ABCs, break it down for me. What does this mean? I mean, I'm going to segue a little bit and talk about the case I asked you
Yes,
recently, who was a silent carrier. And
yes.
and so now the patient's worried, and and we're going to talk a little bit about silent carriers, and why would you need to look at someone's extended family if you have them, and if you don't, what would you do?
Yes. The silent carrier status, especially for spinal muscular atrophy, one of the
Right.
recessive conditions that are recommended by guidelines, which means that a lot of you listeners would have that test as part of your carrier screening. The silent carrier status is a little bit of a tricky situation, and I'll help to break it down for you.
Yes.
So silent carrier to me means that it's a hidden carrier status. It's not something that is visible or clinically expressing itself.
Yes.
And so just like we talked about sickle cell anemia, same thing with SMA, there has to be, both partners must be carriers for there to be an increased risk.
Mhm.
And a person typically has 2 copies of the SMN1 gene, one coming from each parent. Now, if the analysis is saying that there's only one functional copy, the other one's not functional because there's a common deletion in that gene that is typically detected, then the person is considered a carrier. And then if it's saying that you have 2 copies of the SMN1 gene, the first conclusion is, okay, I'm not a carrier. It turns out, though, that there's about 2 to 3% of the individuals in the population who, when they are given the result of 2 SMN1 copies, those copies are not necessarily on 2 different copies of chromosome 5. They could actually be what we call in cis or adjacent to each other on the same copy of the chromosome, which means that they could still be carriers because the other copy is non-functional,
Right.
even though the lab is telling them that you have 2 copies of the gene. And so that is what's called a silent carrier status. And a lot of the testing that's administered now through various different carrier screening labs cannot tell the orientation of those genes. It can only give you the copy number, but it can't tell you if they're in cis or what we call in trans.
So
And so
cis is they're both on the same DNA gene, and trans is they're both on separate genes.
Yes,
Correct.
we have two copies of chromosome 5. They have thousands of genes. One of those is the SMN1. So by nature, we're going to have one copy on each, so that when our body is making sperm or egg, it's going to pass down by random chance, either whichever copy. And so if both of them are now adjacent to each other on the same copy of the chromosome, that really means that the other one, which could be passed down to an offspring, may have a non-functional gene or a deleted SMN1 gene. And so there's been recent literature that indicates that when individuals are positive for something called a SNP, single nucleotide polymorphism, think of it as kind of like a spelling error that doesn't really change the meaning of a sentence. It's just a marker. And they found that when they detect that SNP as positive for some individuals, it increases the chance that the two copies are actually adjacent in cis rather than in trans. And so this is especially true for individuals of African American descent or Ashkenazi Jewish descent. And so it really means that your risk is increased to be a silent carrier, but it doesn't guarantee it. So that's the only loophole of testing for SMA.
So clarify for me. So you do the SNP and it tells you that it may be cis confirmation.
Yes.
And which one is the worst one, the cis or the trans?
No, well, if they are in cis, that is the silent carrier because it means that the other copy because that means the person is a carrier essentially.
Right.
But if the SNP is positive, the caveat is that most of the time individuals are not they don't have the in-cis orientation. I know it's complicated, but you could have. I did speak with somebody in the industry, and they said it's very common in individuals of African American or African descent to have a SNP positive result, 2 copies of the SMN1, and end up not having any increased risk for their children. It's just a very common carrier status in the population to be positive for that SNP.
So if we have that, like you said, and they have the SNP, but they're in cis, should we panic to go say, oh my gosh, we need to find out if the embryo, is involved, or, what should patients do? Especially both partners, have that.
Yes, the simple answer is no. We don't need to panic, because even if both partners have 2 copies of SMN1 and are positive for the SNP, still the reproductive risk to have an affected child is something like 1 in several thousands of a chance. And because the chance is still considered small, offering things like PGT or prenatal diagnosis is not indicated.
It's not indicated.
Yes. And so we don't need to panic. It's further refining your risk just so you're aware, but there's no action necessary. And, some individuals recommend parental testing because if you look at your parents, then you maybe are able to decipher the orientation. But most of the time, parental testing is actually not that helpful because both parents may also be positive for the SNP and have 2 SMN1.
And then you're back to square one.
Back to square one.
Right.
Exactly.
So I think the bottom line is then when we get this result, it's really important where patients go receive their genetic counseling from, to really talk to someone who has a good grasp of this topic, so that the patients don't panic and end up spending thousands of dollars doing further testing that may not be needed.
100%, because as you've experienced, Dr. Famuyiwa, just getting any kind of positive result on carrier screening can raise patients' anxiety, especially if, the pamphlet we're given or the recording that we've listened to as pre-test counseling, did not register, too strongly. So just by nature of getting a positive result can be really anxiety provoking.
Yes.
And so when you get a carrier situation like this, it even raises anxiety more. So exactly right. Speaking with a genetic counselor, understanding what all this means, and leaving the consultation feeling relaxed, like, okay, I understand this further refines the risk. It doesn't give me an increased risk. Then that should help.
So I think I would say to my audience, people, look, it's really worth it. Penny wise, pound foolish. I think it's really worth it to invest in talking to a genetic counselor when you get this result, correct?
100%. Yes,
All
I
right.
know it's not very easy for all clinics to integrate a genetic counselor as an in-house part of the team. And so, yes, speaking with a counselor who's independent, as in a third-party counseling company, or even in person in your region, can help you a lot.
Excellent. Now, before I go to my next topic, I want to talk about the ACOG, American Congress of OBGYN, recommended screening and everything. Just before we go to that real quick, can you just highlight another very common disease in West Africans is G6PD deficiency, right?
Yeah.
And that's, can you tell us a little bit about that? And why should someone who tests positive be worried?
Yeah, so G6PD is actually a recessive condition. It is X-linked, so it's carried by females, but it can also be carried by males. The idea is that it typically affects males more severely, but this is a condition that allows that basically reduces the activity of a specific enzyme and may result in sort of bouts of weakness or lethargy, especially if the person is exposed to specific environmental factors like fava beans or methyl. I forgot what it's called. So there are certain antibiotics.
Yes.
And so it is in general a condition that is not causing a chronic illness. And only by exposure to those specific factors would a person undergo these bouts. Yes. And so because of that, I would say that generally speaking, this condition is considered on the milder end of the spectrum of conditions. And being a carrier doesn't always justify necessarily pursuing PGT or prenatal diagnosis.
Exactly.
So I hope that helps the audience. And they can speak further with a genetic counselor to kind of further understand. Yeah.
Excellent. So, and I know you mentioned PGT a couple of times, but before I go to PGT and PGT, I'm like, what's all that? Alphabet or something. So before we do that, let's talk a little bit about what does the ACOG, American College of OBGYN, what do they recommend?
Yes. So ACOG guidelines for the longest time were recommending a core panel of about 4 conditions that should be universally offered to individuals. These conditions are cystic fibrosis, spinal muscular atrophy that we talked about, hemoglobinopathies, and then Fragile X for females, especially if they have a family history of the disease. Now, in about 2016, 2017, there was additional language that was added to the committee opinions of ACOG to say that use of pan-ethnic or expanded carrier screening is an acceptable form of screening for individuals seeking a pregnancy or are currently pregnant. And so that allowed a lot of physicians to then utilize these available tools, especially if it fits their patient population.
Exactly.
If they have a diverse patient population, veering away from necessarily specific ethnic-based panels may not necessarily be serving their patients anymore. So that's, and also the guidelines are saying that each practice would set their own standard for the care and the panel that they deem is appropriate, but that also that pre-test and post-test counseling is absolutely integral. And so I hope that helps patients understand that you are in control. Ask questions, see which panels would suit you best, and if you'd like to learn more or less information.
Love it, love it, love it. Thank you so much. Now let's get to the alphabet soup.
Sure.
PGTM, PGTA, what gives? What is it?
Yeah, I actually started the conversation by saying that we have 2 different tests, genetic tests to think about, and never actually talked about testing for embryos. So thank you for asking me again. So PGT stands for pre-implantation genetic testing, and it's basically testing that's done on embryo biopsies to then inform the couple of information that would help them prioritize the transfer of their embryos. And there are different kinds. So there is PGT-M, with M standing for monogenic conditions like cystic fibrosis, where you are specifically, you have a knowledge of what mutations to look at, and you're investigating the presence or absence of those in embryos. There is something called PGT-A, with A standing for aneuploidy, technical term for basically chromosomal imbalance. There's PGTSR, structural rearrangement, where some couples, especially if they have a history of frequent or recurrent pregnancy loss, may benefit from looking at their chromosomes. And if they have a structural rearrangement, like a translocation, where two pieces of chromosomes can break off and swap places, it may not affect the person personally, but may increase their risk for aneuploidy, then that could be relevant. And there's a newer one called PGTP, with P standing for polygenic conditions. Things like, multifactorial diseases like diabetes, Alzheimer's, schizophrenia. And so they all have different applications and different points of when they could be used.
Excellent. Thank you for doing that. So thank you so much. I'm really enjoying this. But then I'm a nerd with genetics here. So let's talk about, we mentioned briefly about genetic testing in a diverse patient population. Like, I see a lot of Africans, a lot of Asians. You see a lot of Middle Eastern. There are people of, maybe Irish origin or, South American origin. What would you comment about the unique challenges of such testing?
100%. So I would say that because of this really diverse ethnic background, looking at pan-ethnic panels is actually a great idea. It does cover testing for a lot of individuals, regardless of their ethnic background. But the other challenge I see sometimes with internationally based patients is that sometimes they get that testing in their own countries. They come to the United States briefly for fertility care, and they are shocked by the fact that maybe a repeat analysis for the testing is recommended, just because, in the US, maybe the use of CLIA certified labs is more favored.
Right.
And so it can be a little bit of an obstacle, just because they've spent money and time, and they probably will get the same results anyway. But it's a step that sometimes needs to be considered in order to be offered additional testing. And the last thing I would say is, using pan-ethnic panels is really, really great. Just know that there's one caveat, is that if you're heading back to your home country after having that testing done, and let's say that you are using a gamete donor, or if not, let's say that your partner was tested elsewhere, sometimes you can get a phone call back to say, I think additional testing needs to be done for you because there's a discrepancy in the panels used for both partners. So these are some things to consider with testing, but the underlying point is that it is essentially really helpful for risk assessment, and to consider those tests is really important for care.
So we're about to be done. Thank you so much. I just want to jump in here and say, I know people have, and this goes back to one of my patients who I begged to get genetic carrier screening done. She goes, nah, I don't want it. Nah, I don't want it. And then she went to a different country to do IVF because, it was more cost effective over there. And turned out that she had twins, and they have a genetic disease that I never heard of in Africans. And now it affects the twins' kidneys, and they have to take, I think they have to take potassium supplements for the rest of their life. They have to, right? And I could see and hear the pain in her voice. I mean, her kids are fine. One of them has Down syndrome, but they have this condition that they have to be medicated for the rest of their lives. So this is really something that shouldn't be trivialized, and we would highly recommend it. So
100%.
Yeah. Okay, before we close up, can you shed some recent data on any of the latest advancements in genetic research that are exciting or upcoming, or where is the future with all of this?
The future is definitely in personalized medicine. There is a lot of active research on ways to improve fertility care. So I'll mention a few because I know they're very complex topics. But one thing that you hear a lot about these days is artificial intelligence, AI. And it's used in our search engines and everyday life. But now it's the thought process is to use that in the fertility care, such as, for example, using it to look at time-lapse imaging of embryos to see if we can prioritize the grading of those embryos. Another point of research is single genes that could be associated with infertility. So there could be panels not offered as carrier screening for the public, but there are specific genes that affect maybe ovarian development, oocyte development, embryo development. And then if we are able to identify those, then maybe there is some personalized medicine, like certain drugs or certain ways that we can allow, help these patients with care. And last but not least is, you probably heard of non-invasive PGTA testing.
Absolutely.
And so that's been offered for a couple of years, if not more, but it's advancing as we speak.
Yes. Thank you so much. We've learned so much today. And if anyone wants to know how they can reach Ms. Awwad and wants any counseling, please reach out. I'll give you her contact easily. And she's very happy to shed some light for you. Once again, I want to thank you so much for your time.
Thank you so much for having me.
All right. So and if we have any follow-up questions, we might have this again. Thank you.
No problem. Anytime.